Oh. No problem. All righty. Can we get back? Great. So what I'm about to do is, over the next 40 minutes, is, let me see. Oh, the slides are still not working, sir. I'll give you that. Wait, they're not changing, if you don't mind, get it to. Thanks. So what I'm going to do over the next 40 minutes is take a step back from this morning's talk. This morning we focused in on nocturnal events, paroxysmal events in sleep. And what I hope to do is take let me again thank our sponsors and our mentors who really do appreciate being here, and thank you all. What I hope to do is really key in on an aspect of sleep, and sleep as a function of the brain. Really try to walk you through how we can utilize sleep as an opportunity to improve brain functions as well as improve other body function. I understand that many of you are general practitioners, and so I'm going to spend a little bit more time on general medicine in regards to this, but I will point out how this is really an opportunity for us to think about brain function and how we can use it as an opportunity. We all understand that sleep is essential to our health. We know that literally, after about 17 days or so, you can't stay awake. You have to sleep. Your body will fall asleep. I also, though, want you to understand and come away with a point that not only is there a benefit from sleep, there's also a benchmark. That sleep and sleep disorders may actually give you clues as to what's going on during the day. It may give you clues to how to handle other issues that the patient may be having. And I think Dr. Vincent really drove that home with the Marfan's syndrome and some of the antibody autoimmune issues where sleep is a component. And then hopefully walk through and show you how sleep is really part of the quality of life. So we're going to talk a little bit about sleep physiology. If I don't know what medical school is like in India. In the US, the average medical student gets less than 1 hour of training in sleep medicine. So it's relatively limited. So I'm hoping if you're similar, I'm going to double the amount of education you've had in sleep. We'll talk about excessive daytime sleepiness, and then a little bit, we're going to change gears, narcolepsy, and then we'll talk about restless legs and walk into the insomnias. But let's jump into some of this. So we know there's benefits of sleep. We feel better. We may have better functioning. If we don't sleep well, I think all of us will notice we're a little bit more irritable. We may not be quite as sharp as we could be. There's actually a higher risk of depression. Interestingly, there's a lot of evidence now that poor sleep will promote weight gain and some risk of accidents. In fact, I don't know, this is an American cab driver. This is a camera that's in the cab. I'm hopefully not scare you to come to America, but this is what was recorded in the cab. I want you to notice his eyes. Notice his eyes. He's a little sleepy. He says an expurlative at the end. He actually is fine, although a little shaken up. So this is not to scare you about coming to America, but it is an important issue because if you fall asleep while you're driving or performing certain tasks, you may not be able to perform at your optimal event. And so this is not uncommon. In fact, we have a lot of very famous accidents that we now know are related to sleep. In the early 1980s, we had an accident at 3 Mile Island, which was our first nuclear accident. The key decision that led to the pumps being closed, water pumps being closed, was at 4 a.m. In the morning. The Exxon Valdez accident was at 11:35. A third mate that was steering the vessel had been up for over 24 hours before he didn't read the maps as they were going out of the channel. Chernobyl, the critical decision led to meltdown there, was about 1:23 a.m. Our Space Shuttle Challenger accident back in the late 80s. The decision about go or no go, if you remember, was whether the O-rings would tolerate cold weather. That was made by an engineer at 5:20 a.m. who admitted to average sleep of about 3 hours per night for the 3 weeks prior to the liftoff. And in my own work, we've looked at auto accidents across North Carolina. It's somewhere between 15 to 25% of auto accidents have either fatigue or sleep as a relation. And that ends up to about $150 billion a year in the U.S. of either lost productivity or accident-related payments. So it's a significant economic effect on us. So I did promise you that I was going to talk a little bit about neurology. If we look at patients with neurology, does sleep ever influence them? Well, we know that patients who have headaches are actually 2.5-fold more likely to have complaints of sleep. We know that there's a high incidence of sleep apnea in our stroke patients. We know that epilepsy patients more likely to have excessive daytime sleepiness, more likely to have insomnia than our general population. Diabetic neuropathy, the use of hypnotics in our patients with diabetic neuropathy is above, it's over twice what we have in the United States, and about 50% of our diabetics complain of insomnia, nearly 3/4 of our Parkinson's patients. And one of the more important issues that I think is, as we in America are getting older and having greater instances of dementia, but sleep issues are really one of the key issues that leads to institutionalization. So what are the factors? What drive us to sleep? Mainly, there are 3 major drivers for sleep, and we're going to talk about 2 of these based on physiology. One of the things that we recognize is we live in a world that rotates, and in fact, Dr. Pedley and I came across about 10.5 hours of time zones to come here. So we're acutely aware that our body clocks may not be in sync with the environment. But the idea is that your body is not the same throughout the 24-hour period. In fact, recognize that the whole idea of homeostasis really doesn't exist. There is no 2 points in that 24-hour period where your body's exactly the same. It doesn't respond the same. You don't have the same immunological, endocrine, autonomic responses. In fact, if you plot out the body temperature curve, typically we're reaching a low at about 4 a.m., you have a peak around noon, you have a little dull after lunch, and then you reach your higher peak in the evening around 8 o'clock. So I will point out that we all understand you are right here, another lull in your circadian rhythm, and I'm right there. So we'll do our best to get through this. Now, reason we have a circadian rhythm is the fact that we actually live in a world that rotates. And so our circadian rhythm is really to try to optimize, to predict what our body will be doing, what's the activity that's coming up. That's very interesting because in this evolution of our circadian rhythm, we understand that this is a genetic clock. This is really a genetic clock that uses a complex double feedback loop to create approximately 24 hours. It's actually about 24 hours and a third, not exactly 24 hours. But with that clock, we understand that somewhere between 2 to 10% of our genes actually oscillate. In fact, Dr. Pedley and I were talking about the fact that in epilepsy, it's very interesting that many of, or several of our genetic epilepsies have a circadian rhythm or have a sleep-related dependence. And part of this, we were postulating, is wonder if they're in those groups of genes that actually oscillate in the circadian fashion. In fact, we understand that circadian rhythms play such a significant role in how our bodies respond. Literally every organ has some event of oscillation through the day. This includes your reaction to drugs. So if I gave you cyclosporin, or cyclophosphamide at 5 a.m. versus 5 in the afternoon, the 5 a.m. dose would have 1/3 the amount of adverse reaction, including the drop in your white blood cell count, using the same population, just 2 different periods of time. So the point of this is your body does not react the same. And in fact, that's actually being studied in oncology, and we know that oncology patients, given chemotherapy at certain specific times, have much better responses and lower side effects. Now, in addition to that, we can manipulate that body clock by the use of bright light, exercise, social interactions, and food. And in fact, predominantly, these promote wakefulness. These all give us the idea that it is time for us to be awake. Bright light actually being the most important. So if we want to shift this clock, if we want to phase shift, this is our body clock, if we put bright light before the peak, or actually before the temperature nadir, which occurs at around 4 in the morning, what we will do is we'll move our clock later. We can delay that sleep phase. If, however, we put the bright light after the temperature nadir, we'll actually advance our body clock. We'll move it backwards. We'll make ourselves go to bed earlier, and we'll wake up earlier. So this is an easy way to shift your body clock, and in fact, bright light does it about more effectively than any other stimulus. I'm going to slide through this one. That's not supposed to be there. So the keys to the circadian rhythm really are having a regular schedule, making sure that we can predict. We know that we have abilities to manipulate that clock, and we may have some other components that may actually help accentuate that temperature curve. So in addition to the circadian driver, we actually also have what's called the homeostatic driver. Now the homeostatic driver is where we build up substances for as long as we're awake. And so as we're building these substances up, these substances will build up through the day, and when the homeostatic driver gets above our circadian driver, so our circadian driver keeps us awake, our homeostatic driver wants us to go to sleep. When our homeostatic driver is above our circadian driver to stay awake, we'll fall asleep. And we typically sleep through the night. And as we sleep, these substances decline. They get metabolized a little bit better. And subsequently then, we will again be back at the morning time when our circadian clock or our circadian drive to stay awake overwhelms our homeostatic drive. And therefore, we're going to be back awake. There are certain things that build up in our brains that we know, adenosine probably being the biggest key. I know we just had coffee and tea a little earlier. The most common way to block adenosine is with caffeine, and that is probably one of the major components of the homeostatic drive. But there are a host of other neurochemicals, neuroactive chemicals that provide this capacitance to push you to go to sleep. So if we think about it, we have our homeostatic, our circadian drive to stay awake, our homeostatic drive to push us to sleep. This explains a lot about how we typically react. So if we don't pay off our homeostatic drive at night, we're a little bit sleep deprived or we're a lot sleep deprived, what happens is we see that our homeostatic drive is actually at a higher level, so we're sleepy after we get up in the morning. We may fall asleep during that boring sleep lecture that occurs in the middle of the afternoon, or we get sleepy in the evening. And this is while we still have our peaks of our circadian rhythm, making us giving these time periods that we feel more awake during the day. If, however, we happen to start taking caffeine and we have a normal homeostatic drive, we actually suppress this homeostatic drive, which in essence, depending upon how rapidly we metabolize the caffeine and how much we take, will actually make this either have trouble going to sleep or staying asleep through the night and may fragment our sleep. In addition, if we think about what happens if we take a nap, why we can't sleep at night, is that we'll start out with a higher homeostatic drive. You take a nap during the day, you burn off some of that homeostatic drive, and then again, you may have trouble falling asleep at night because you don't have as much homeostatic drive. So this two-driver model actually gives us a lot of basis for figuring out how to manipulate the sleep-wake cycle. In addition to the sleep-wake cycle, we also, as I talked a little bit earlier, have the three states of wakefulness, non-REM sleep, and REM sleep, and each of those have their own physiology on top. We typically determine those currently by the basis of eye movement, EEG, and muscle tone, but those are only three of components of hundreds that actually change with sleep state. And we've just picked those as our standard three. If you come to my lab, you're going to get full set of EEGs, you're going to get eye leads placed, you're going to measure your temperature at your nose and at your mouth, we're going to measure the pressure inside your nose, we'll have a band around your chest, a band around your belly. You're going to have electrodes on your arms and legs. We're going to measure your EKG. We will have intercostal EMG. We'll have an oximeter on your finger. We'll have a couple other things. We may even put an esophageal pressure monitor down. And if you're really nice, we'll put a rectal temperature probe in. And with all of that, we'll watch you sleep. Volunteers? Not many volunteers. Interestingly, we do about 2,500 studies a year, and probably about 3 or 4 people can't sleep with it. But we take all that data, and we can graph out what's called the hypnogram. And I want to bring out, this is an ideal hypnogram, where we've graphed the stages of sleep across the night. And this actually gives us a lot of pieces of information. And one of the things I want you to walk away with is understanding that sleep is very active. It's not turning the light switch off. It's turning a different portion on. And in fact, when you look, you'll see that sleep has cycles through the night, and it also has a progression. So we have cycles occurring about every 90 minutes through the night, and we have a progression, progressively less slow-wave sleep and progressively longer periods of REM sleep. And so if we're looking at disorders that are predominantly related to slow-wave sleep, deep sleep, they're in the first half of the night. When we're looking at disorders that are more REM-related, we're looking at those being in the latter half of the night. Okay, so as I said, I know this is a post-lunch talk, so the gist of this is if the bait fish are gone, maybe something, they're smarter than you are, and maybe something about ready to eat you. So let's go. Okay, so let's think about this. About 1 in 3 individuals in the U.S. have a complaint in regards to sleep. They're predominantly break down into several categories. We know that about 58% of adults snore. We know that about 36% of adults will complain of insomnia intermittently. About 15% of the U.S. population complains of excessive daytime sleepiness that interferes with their ability to work. About 3% have unusual events. And about 28% of our workforce does rotations. So let's talk about excessive daytime sleepiness. So I provide this not for you to memorize or understand, but I want to give the big picture. If we're going to approach excessive daytime sleepiness, we really need to think of the physiological models. So is this a circadian rhythm disturbance? Is there something disturbing the nighttime sleep? Is this related to not getting enough sleep? Or is this an injury or something wrong intrinsically in the brain? So is it homeostatic drive? Is it circadian drive? Is there something disturbing sleep? Or is there a problem with the mechanism? So we're going to approach those. Now here we go. Sleep debt, disruption of sleep, a control, or a body clock issue. So let's talk about sleep debt, because this is probably the most common reason for excessive daytime sleepiness, at least in the US. And it's certainly when we see a shortened time devoted to sleep. Many people think that sleep is kind of a luxury, really not an item that is a necessity. And what we know is that really, if you're sleeping an hour short per night, then you're about 365 hours short after a year, or 3,650 hours after 10 years. It's very hard to make that kind of sleep debt up in a weekend. And we know this is very similar to borrowing money like from a bank, that you need to pay off those hours, although it may not be exactly one-to-one. What we also know is that when you have sleep deprivation, if you've allowed your homeostatic drive to go up, or as your homeostatic drive is building, we also know that your performance declines. And so when you are performing at about 18 hours of wakefulness, we know on a performance vigilance task that you're going to have more errors in that. And that number of errors is going to be similar to having a blood alcohol level of about 0.06 to 0.07. So there is a rebound, there is a circadian component to this, and everybody needs to recognize that. But very clearly, you're not performing at your peak. And so sleep deprivation, we know, can increase problems with mood. We know that it has a influence on your memory. You have when you are sleep deprived, you're more likely to remember negative events than positive or neutral events. We know you're less consistent in your performances, especially in monitoring tasks, which is why driving becomes an issue. It's a monitoring task. active. If you're being challenged and asked to do math questions, you're not going to have much of a decline, but clearly doing things like driving are going to be hard. And we know that weight gain is more prevalent in people who are sleep deprived. Sleep apnea is actually also a concern, and as a neurologist, I'm going to tell you that this is also an area where neurologists need to be involved. This is where we have episodes of airflow that are diminished. It comes in two major forms, obstructive and central. When we think about them, we teach these as two separate issues, but they're actually the same issue with two different forms. So what I have here is a cartoon of airflow and esophageal pressure or intrathoracic pressure. Obstructive events are where you have a loss of airflow, but yet you still have swings in esophageal pressure. In central apnea, what you have is a loss of airflow, but no swings in intrathoracic pressure. So how could these be the same event? How could they be anywhere close? They seem like they're completely different mechanisms. Well, from a neurologist viewpoint, airflow is abrupted here is because the upper airway muscles have relaxed and you form obstruction. In central apnea, it's just the lower respiratory muscles that relaxed here, and you get a pause. And in many times when you see patients with central apnea, they also have obstructive apnea. It's very rare to see it so that it's just one type of apnea by itself. You many times see both forms together. And I think this is a reflection of the fact that a significant portion of obstructive sleep apnea is not, even obstructive sleep apnea is not just structural. It is a neurological component to it. If it's pure structure, then those patients will snore during wakefulness. So it's an important point that there's a state component too. About 9% of adult males, about 3% of adult females have obstructive sleep apnea, and typically they present with excessive daytime sleepiness and the complaint of snoring. We've done, we had in the US a sleep heart health study, which actually examined about 3,000 individuals and found actually when we did polysomnography on these individuals, a relatively very high rate of sleep apnea, mild, moderate, and severe, which was concerning. And the second point that was concerning was that even after 5 years examining the same individuals, we saw a rise in the rate of obstructive sleep apnea. So why do we get obstruction? Or where do we get obstruction? Well, we certainly know that it's multifactorial, and this is one of the reasons that surgery doesn't work. We see obstruction not only in the nasopharynx, but in the oropharynx and just above the epiglottis. So all of these areas obstruct. It's very difficult to fix just one area and have a complete resolution because it's not just related to one area of structure. It is related to how the airway muscles are handling the increase in negative force during inspiration. If you're going to clinically try to figure out who has sleep apnea, one of the easy ways is to use what's called the stop-bang questionnaire. And this is, do you snore? Are you tired? Has somebody witnessed you stop breathing? Do you have an issue with blood pressure? Is your BMI over 35? Are you over 50? Is your neck size over 40 centimeters and 17 inches? And are you male? So as I frequently say, well, I'm a little tired, I'm over 50, and I'm male, I have a score of 3. What's my likelihood of having sleep apnea? Well, actually, my likelihood is about 17%. So scores of 3 or higher actually have a significant increase in likelihood of having obstructive sleep apnea. Besides, historically, what do we look for in physical exam? Well, frequently, I look at the vital signs. There's a reason for them being called vital, and I think it's important to take a look at them. So you may see a mild increase in blood pressure. You may see a mild increase in the heart rate. So not uncommonly, if patients have a mild increase in their heart rate, they're in the 80s or 90s, I will be asking specifically about their sleep based on that vital sign issue. Many times we'll get what's called low-hanging fruit, a large, beefy red uvula, although it doesn't show up well in this picture. Horizontal lines are really a very good sign for a lot of snoring. You can see there's a little more redness along the edge, which is again a sign of snoring. And we'll take a look to see how crowded the airway is. When we bring these patients to the sleep lab in our lab, everybody gets nasal pressure monitoring because that is close to the gold standard as you're going to get. If you are going to do sleep studies here, what you want to do is make sure that you are able to get nasal pressure, because clearly by just looking at air temperature in a standard polysomnography, you're going to miss a lot of cases of true sleep apnea. When we look at what's the reason to take a look at these, why in the world would we even be worried? Well, I think it's important to recognize what's the risk. We are treating sleep, but goodness gracious, it's just snoring. So if we look at risk for vascular disease, we generally think that smoking is a significant risk. Has an adjusted odds ratio of about 1.8 to 3.9. Obviously, obesity is about 1.5. Even air pollution has a risk of increasing your likelihood for vascular disease. How does that relate to obstructive sleep apnea? What are the numbers? Well, here's a variety of studies, epidemiological studies, that have implicated sleep apnea, that even though they've adjusted for all the other features, they find that risks for hypertension are in between 1.3 to 2.9. Coronary artery disease, if you're severe sleep apnea, almost threefold. If you're looking at risk of stroke, it's in the 1.5s to fourfold, depending upon what your pre-existing issues are. So there are very significant risks for vascular disease related to sleep apnea, and it's one of the reasons that we want to go after it. In addition to that, if you look at the Wisconsin health study, employee study, what they showed was they had actually much greater risk for death even at the 10 and 15-year mark, so early death. So who needs to get evaluated? Well, typically anybody who snores and has vascular issues, anybody that snores and has unrefreshing sleep, insomnia, or excessive daytime sleepiness. And basically, the one that scares us the most in the US is the American Academy of Pediatrics came out with this previous guideline of all children who snore need to have a sleep study. They subsequently have revised this with some mild modification, but basically it's the same issue. So how do we treat this? Well, we can use a wide range of treatment. The vast majority of patients who are going to be treated are treated in CPAP, the continuous positive airway pressure. This is pretty much like taking the back end of a vacuum cleaner and putting it on a mask and putting that on your face. Can easily have difficulty with compliance. In children, our primary therapies are surgery, because we will take out tonsils and adenoids. Or we may push surgery further in adults. Beyond soft tissue surgery. So in our area, we will break your upper jaw, move it forward, break your lower jaw, move it forward, take out the uvula and palate, take out tonsils, adenoids, pull your tongue forward and pull your hyoid bone forward, maybe even take out your turbinates. And that'll give you about a 50 to 55% chance of fixing your sleep apnea. The only surgery that works all the time is a tracheotomy. I do have patients do that. For our mild patients, we may use more oral appliances, and they can be effective. Some of the conservative therapies, obviously having people sleep on their side. There are what's called EPAPs, or nasal stickers, that sometimes can be helpful. And there is a little evidence that playing the didgeridoo for 45 minutes a day will actually improve your likelihood of that. So I don't know if oral appliances are available here in India, but there's quite a wide range of these. They typically work by jetting your lower jaw forward, and with that, anywhere from about a 30% to 45% chance of significantly improving your sleep apnea. The CPAP I did breeze over, but I want to tell you there's about 110 different models and sizes of CPAP masks. You can see they can come over just the nose or insert in the nose. There are masks that go over the mouth, or the mouth and the nose, or over the whole face. And so there's a wide range of masks that can be used, and it's, I think, one of those therapies that really works best when you align the patient's life goals and make sure that they have gotten through to the point of accepting the diagnosis and working with them to get through the complaints of dry nose, dry eyes, and such. But really, this is one of those areas that persistence will pay off. Let's see. Talked about surgery. So does treatment actually make a difference? I think this is actually a key point. Are we making any headway with this? And absolutely. We know we've got clear evidence that in heart failure patients, if we actually put them on CPAP, they're much more likely to survive. We know that there's a reduction in blood pressure. We also have evidence that we reduce the risk for recurrent stroke. We also have shorter hospital stays for individuals that are treated. In my own work, we've been able to show that depending upon how you're selecting patients with epilepsy, you can reduce their seizure frequency by treating their sleep apnea. In other words, the brain and the body do better when you're sleeping well. If we look across large studies, does we make a difference? Yep. And if we look at the Epworth Sleepiness Scale, a measure of daytime sleepiness, the more hours you wear the CPAP at night, the better you do. Again, on objective measures, multiple sleep latency, and on quality of life, we see quality of life improvements too. So the take-home message here is that sleep apnea is really an important point for us to look at, to have a lot of health risks, and really persistence will pay off. We really make sure that we align those goals. Quickly, narcolepsy is actually our state control abnormality. This one gives us a look at how we can turn on and off sleep, and especially turn on and off REM sleep. It is typically composed of 3 of 4 symptoms: excessive daytime sleepiness, cataplexy, where you have episodes of emotion that can cause atonia or muscle weakness, hypnagogic hallucinations, and sleep paralysis we talked about this morning. But about 1/5 of patients will come in with insomnia, and that's an important piece to recognize, is that it is one of the ways to present for that. It's a relatively rare, about 1 in 10,000 to 1 in 3,000 individuals will have narcolepsy, but the variance actually has a wide preference or variances in prevalence. So we know we make the diagnosis based on polysomnography and a multiple sleep latency study where we have individuals take naps during the day, and we look to see that in the 5 naps that they have at least 2 sleep onset REMs. The main key about this is that this is a disorder similar to Parkinson's where a cell line, a specific cell line, has died off. In the late 1990s, we actually, in early 2000, came across, not us, but 2 different groups, one in Stanford, one in Dallas, Texas. Both came across the fact that narcolepsy patients are the ones that are missing orexin-producing neurons. These are, although they're relatively small, there's only 70,000 of these neurons in the brain. Looking at the normal side, these neurons produce orexin, and in narcolepsy they're gone. And orexin appears to help stabilize the state that you're in. So you stay in sleep or you stay in wake. And then the transition doesn't go back and forth. What's more interesting is some evidence to suggest that there may be an immunological link to narcolepsy, and we've certainly had some outbreaks and waves of narcolepsy following the H1N1 virus and vaccination in Europe. Also, a form of strep has been linked to this. And there's a new test that actually shows T cell activation being discordant in individuals that are HLA-DQ0602 positive, even when we look at twins that are discordant for narcolepsy. The twins that have narcolepsy, the members that have narcolepsy, will have this T cell activation toward orexin peptide fragments, whereas the non-affected twin does not have that. So a lot more to come in that area. Typically, we treat narcolepsy based on the symptoms, stimulants for maintaining their ability to stay awake, or improving it. Planned naps, a 5 or 10-minute nap during the day is as good as modafinil or an amphetamine. We improve nighttime sleep either with sodium oxybate or more recently temazepam, or if they have sleep apnea, making sure we treat the sleep apnea. And the cataplexy is predominantly treated with either sodium oxybate or one of the antidepressants, SSRIs or SNRIs. Let me move on to restless legs. We had a comment yesterday about restless legs and that it was relatively common, and that's very interesting. These some estimates from 3 to as high as 15% restless legs in prevalence in the United States. And my general thought is it's probably on the lower part. But we make the diagnosis on restless legs based on 4 criteria. This is an urge, not a pain, but an urge, a discomfort to move. Many patients may have different words to describe it. They may call it their jiggly legs, or that they feel that worms are crawling through their legs, or an energy source. When they are at rest, it gets worse. When they are active, it is totally or partially relieved. So within seconds of getting up and walking, it's relieved. And the symptoms have a circadian rhythm to them, so they're worse at night. We typically see about 85 to 90% of these individuals have periodic limb movements through the night. This is a 2-minute compressed polygraph. So they periodically move their legs during the night. This can be related to a wide variety of etiologies. Some are iron deficiency, as we talked about yesterday. Uremia is also noted, and inherited neuropathies actually increase the risk of restless legs. Probably some of the more exciting areas of this is that we know that in some individuals, this is related to low iron in the brain. And in fact, what we see is less iron in the patients with restless legs compared to normal controls. And so this has led to some exciting work about iron replacement for those individuals who may have ferritin levels that are 50 or below. And there's some greater work coming with that. Typically, when we treat restless legs, if there is an underlying etiology, such as uremia, we may increase the dialysis time to try to improve that. If there's an offending agent, such as any dopamine blocker or tricyclic antidepressant or even caffeine, we try to remove those. Moderate exercise, relaxation, sometimes magnesium or iron will help with this oral, and even compression stockings may help symptomatically. Mainstay of medical therapy, however, is predominantly dopamine agonists, and in the U.S., these three, ropinirole, pramipexole, and reticotine, are all approved for restless legs, or gabapentin, all seem to have relatively equal efficacy in improving the symptoms for restless legs. Other agents, such as narcotics, can be used. They're highly effective, but once you put a patient on a narcotics for restless legs, they're going to stay there for lifelong. The one point I do want to point out is there is a exacerbation of the symptoms with dopamine agonists. This is called augmentation. The symptoms typically will come on earlier in the evening. They have greater intensity. For most patients, if you take them off the dopamine agonist, this gets better. However, I actually have quite a few patients that have collected over the years that this has happened to and have been permanently worse. So I do caution the dopamine agonists. Typically, I do not use them as my first line, even though that is the current guideline. So I'm going to take the last couple minutes to talk about insomnia and try to go through this. The diagnosis of insomnia is not just difficulty with sleep at night, either initiating or maintaining it, but it must have some sort of daytime impairment. They must have fatigue or impairment in their performance. And typically when we start thinking about how do you approach insomnia, usually when I get the point of insomnia, if it's not a primary thing for referral, diagnosis for referral, it's usually the at the doorknob conversation. Oh, by the way, doctor, I don't sleep well at night. And you usually kind of take the deck and go, okay, how do I get through this? But I think one of the ways to think about it is this an environmental issue? Is this a psychological issue? Is this a physiological issue? And again, we think of it in the sense of, is this a problem with body clock? Is this a problem with some sort of disturbance in the middle of the night, or an intrinsic brain or psychological issue? And that's a good framework to take it through. There are features that certainly predispose individuals for insomnia. Being female, being older age, having a type A makeup certainly makes you more likely to develop insomnia. There are certain things that precipitate it, such as travel across multiple time zones, acute illness, new medications. All of those may start the insomnia. But for chronic insomnia, the real money is right here in perpetuating factors. Things that we do that actually may make the insomnia prolonged, or that the prolongation of the insomnia may be an indication of other brain issues. In this, I do believe the history is key, and it's taking a great history of what's going on both during the day and the night, the time course of the insomnia, is all key. The attitudes towards sleep are very good, very important pieces. There are certain prototypic insomnias. We know idiopathic insomnia starts in childhood. These folks are more likely to have brain issues with the mechanism of sleep and wake. And really, these are patients that are most likely going to be on medications and need to be treated. Psychophysiological insomnia, these are individuals who sleep better when they go to a different place. So if they go away from home, they may sleep better, but they have several maladaptive behaviors. So this is an association issue. Affective issues, obviously asking about depression or anxiety, adjustment disorders, certainly you can note the events. And paradoxical insomnia, the typical history with paradoxical insomnia, these are people that say, "Doctor, I haven't slept in 17 years. I never sleep," right? Those people have paradoxical insomnia. They misperceive the ability that they're sleeping. So they perceive themselves as awake even though they're asleep. And obviously we think of the other two that we talked about. So my approach to insomnia is thinking of it as having 4 flat tires on your car. This is you can change one of the tires, the car still doesn't run. It doesn't mean you did the wrong thing. So many patients with insomnia will say, "Oh, I've already done that. Oh, I've already done this. Oh, I've already taken that." That's fine. Take the approach of 4 flat tires. So what are the 4 flat tires? Well, the 4 flat tires are, we have to maximize our physiology, circadian rhythm and homeostatic drive. We have to lead the body here. We have to break bad habits and beliefs. That's the cognitive behavioral therapy. We may consider medications, and we always have to treat underlying affective issues. So what's the first part? Well, we're going to make sure that we regularize the schedule. We're going to maximize that circadian rhythm. Potentially no naps during the day. We want to make sure that they take a hot bath to maximize their body temperature at night, and maybe an aspirin, move it from the morning to the nighttime to accentuate that drop in the body temperature. We may have them exercise during the day, again, to get the body temperature up a bit, and we're going to avoid caffeine and alcohol. So basically what we want to do is we want to get that relatively flat circadian rhythm where they're intermittently fatigued and sleep, to one where we can improve the amplitude of this by making sure that we've been able to go and accentuate the body temperature curve and increase the homeostatic drive at the appropriate time. So we're going to add exercise in the morning, bright light in the day. We may have aspirin or hot bath or melatonin in the evening. Let's see. Boom. So we also, our second flat tire could be that we use non-pharmacological therapies, cognitive behavioral therapy, stimulus control, where we actually try to reduce the amount that's stimuli in the bedroom, relaxation techniques, and cognitive restructuring, make sure they have the right expectations. Not everybody has to sleep 8 hours a night. And really working on making sure that they have improved amount of sleep while they're in bed, shortening their time in bed. Let me focus in on the sleep restriction therapy. This is a little bit counterintuitive. This is a therapy where you ask the patient, how many hours a night do you sleep? Oh, I sleep 5 hours? Great. We're only going to let you be in bed 5 hours. So as long as they're sleeping greater than 85%, they may be able to increase the amount of time in bed by 15 minutes to 30 minutes. If they're sleeping less, you shorten it by 15 or 30 minutes. And eventually what will happen is they're going to build up enough sleep debt that they're going to burn through the maladaptive behaviors. They'll consistently start having a greater likelihood of 85% sleep in bed, and then it seems to work over time that they learn what's the amount of time that they need to be in bed to sleep. Tire 3 is of drugs, and if for sleep onset, we may use short-acting hypnotics like zolpidem or Xalapon, or herbals such as melatonin. For maintenance issues, we may use more extended release, isoprolol or zolpidem continuous release, or use selectively inhibiting the histamine receptor by using either low-dose doxepin or low-dose mirtazapine, or now we have evidence that low-dose trazodone does the same thing. So all of these are options, or using gabapentin, because we know this is also a drug that helps improve sleep, improve slow wave sleep. So in tire 4, is that we have to make sure that we're going to check out for affective disorders, and we really want to make sure that we use combined therapies for these individuals if they are depressed. So an antidepressant and a hypnotic actually improves the likelihood of both outcomes than either drug by themselves. So go through again, we're going to maximize our physiology. We're going to break the bad habits by using cognitive behavioral therapy. We're going to consider hypnotics. And we're going to treat our affective issues. So I know I've run over, I apologize, but I hopefully been able to walk you through a pretty wide variety of sleep issues, showed you how sleep issues can affect you during your performance during the day, how you're feeling, and how these have an implication on your health and on your brain. So I'm happy to take questions, and again, thank you very much.